She won most talkative in high school, and she has been running her mouth ever since. Welcome to the Lisa Fisher Said podcast with your host, Lisa Fisher.
Okay, kids, we've got your mom's gynecologist on. Isn't that what you say on your social media?
Especially when I'm clapping back at
Oh, I know. Girl, I know
a
when
certain
it comes out.
demographic.
You're right.
I am, when a 25-year-old, well-meaning, usually personal trainer-esque type person
Always,
comes after
right.
me, I try to explain who I am to their mothers.
I love it. And it's often, it is, so the root of this is, now we all know you from the Galveston diet. We thought that's why you were famous. And then you just made a big splash on the TikTok that the young whippersnappers use. And then I get you, because I don't want the Chinese government to know all my personal secrets, but I'd love for Mark Zuckerberg to, because I'm clearly on Instagram, where I also see you and you also have that message. So what was your first pushback? Was it from Galveston diet, or the fact that you were telling people you can get bioidentical hormone replacement even if you've had cancer, or something else you've said?
My first kind of toe in the water with social media was talking about nutrition and menopause, and really shying away from all the talk about calories and trying to help women understand that this calorie counting is not really serving us anymore at this age. It's not really working for anyone. And that's where people who have built empires off of programs around calorie counting really came after me.
I'm from the intermittent fasting world, so I get a lot of pushback. In fact, I was asked to speak at a big group recently, and they said, it was like making New Year's resolutions, and they said, don't go into the whole intermittent fasting thing. And I went, then I can't speak, because my whole life, my good health and everything, they said it's just so offensive and divisive. And I went, what is offensive and divisive about putting your fork down for a few hours? Maybe, until tomorrow. But that our country now, I think, is so divided, Dr. Haver, into everything's so binary. You're either this or this. Well, can't you admit, though? Can't the personal trainers admit now that maybe we're onto something? Maybe counting calories isn't the best way for a woman who's approaching 35, 40. How did you figure out that message?
Well, really, I had to bang my head against the wall for months. And it was my husband, actually, who, I was menopausal. And when my brother passed away in 2015, I went into this deep depression. And in that depression, all exercise and nutrition went out the window, what I thought was good nutrition. And I gained probably 15, 20 pounds through that grief process. And then when the grief started to lift, I realized I was menopausal and I had this new abdominal fat that had never been there before. Okay, well, let's go back to the tricks and all the things I used to do to get it off. And I could not. I mean, it got to the point where I was calorie restricting to maybe 900 calories a day, like really dangerous, like horrible.
Yikes.
But I was like, this has to work. I've told this to patients for 20 years. This is not like, and I checked my thyroid. I did all the, that kind of stuff, not realizing what it was happening to my body with age and menopause combined. So,
and grief. Wouldn't you say grief and cortisol?
Yes, all of it.
Okay.
You can't isolate these things.
Right.
So my husband caught me, like, I would get up at night to pee because menopause, and I'd weigh myself. I was like weigh myself multiple times a day. I was setting my attitude based on what the scale said for the day. And he kind of quietly pointed out that my children were watching, and they were both teenagers at the time. And that really hit home. And he was going on a trip overseas. And I said, when you get back, because it was going to be a few weeks, you're going to have the wife you deserve. I'm going to look X amount away. And it was all vanity. It was not about health at that point. And he said, I love you. I don't care what you look like. I think you look great. But this is not healthy. Like, you are in this mental, like, you're a scientist. Figure this out. What do you keep telling the girls? If something's not working, you must change the approach to the problem.
That's right.
So that kind of like shocked me into, okay, I got to look at this differently. So, being type A, connected to a big, large academic institution for medicine, I called up all my patients who were nutritionists, who were dietitians, PhDs, and said, what the heck is going on in menopause?
Mhm.
Why can't I lose this weight? Why are my patients not losing weight? Like, this is going on. This is before social media. And they were like, well, you're on to something. We've got a lot of studies in the very elderly, and we know about 25-year-old athletes, but we have to extrapolate between the two. So we know this happens in menopause. Inflammation goes up, insulin resistance goes up, cholesterol goes up. I was like, oh, my cholesterol is not my fault. It's because I'm menopausal. Like, oh my God, and so it just brought me, they sent me all these articles and brought me down this rabbit hole after rabbit hole of nutrition and inflammation, and nothing talked about calories, nothing. It was all about the quality of your nutrition, anti-inflammatory nutrition, Mark Mattson's work on fasting with neurodementia. And that's where my plan kind of started solidifying. I was like, what if I stopped counting calories? What if I just so
How hard
scarily,
was that
oh
for
my God,
you?
it was like everything I had known my whole life.
bet.
It was what I was taught in medicine. Literally, I grew up in the era, I was taught in the era of, if you're fat, it's your fault.
Oh, I
It's
hate
all about
that. Oh,
willpower. You have a eat. I was so fat phobic. I was so prejudiced against
mm,
people with weight problems. And I mean, it makes me sick today to think
mhm,
of that. And not
mhm.
now that I went back to school at Tulane, I took their culinary medicine course, got certified,
Really?
blew
That's
my mind. I
awesome.
felt like called to do it. Like,
Awesome.
this is my path. This is my passion, but I need more data. I need some gravitas behind me on
Mhm.
this. So I did the only thing I could do rather than dropping out of medicine and going back to college,
Right.
to get cert. So I got certified in culinary medicine, which was really the greatest thing I've ever done, and why every
Wow.
physician doesn't have to do this as part
Yeah.
of their training.
Mhm.
I hope we're headed in that direction. So I took all of that and, I made a little program for my patients and myself, and it was working and everyone was happy. Then I started talking about it on social media. Boom.
Oh, then you were a target.
That's where, but I just stuck by my guns because my patients were telling me it was working, and these followers were telling me it was working, and thousands of people were starting to do it on social media. And I was just getting all this feedback that this is actually working for us.
Because don't you think really part of the pushback too is clinical or nutritionists are, I mean, they're paid for by big food and big pharma. So they're telling at the hospital, they're giving them jello and low fat milk. And there no my daughter recently came back from Thailand, was very sick, ended up having typhoid fever. And she is kind of a pescatarian, which she's 25, so I guess it's okay if she is at that age. But we had to buy her, I had to have food prepared here at my home to take to her because there was nothing that they said, well, we've got margarine. Like that was a good thing. So I mean,
Right.
aren't you kind of fighting the battle amongst your own peers and the people that you
So
live amongst?
fortunately, at the university I was at, aside from the people who work for the dietary component at the hospital, these are people who were PhDs doing active research, mostly in the elderly, on protein synthesis and muscle
Oh, okay.
retention.
Yeah.
And I mean, it was blowing my
You were
mind.
lucky. You were
I
lucky
was lucky. Yeah. And my
because
daughter, remember, my daughter just graduated from college with a degree in nutrition science. So talk about being held accountable
oh,
for everything I say on the internet about nutrition. My daughter was, couldn't wait to call me out on
so
anything.
is nutrition science then allows them to become dietitians?
Yes. So now the nutrition science degree, really, it's hard to get a job just with that.
Yeah,
Most of the people who get that degree go on to get a master's
sure.
for 18 months, and they work in a hospital, and become a registered dietitian, they have to take another certification exam. My daughter looked at all that about halfway through her undergrad, and that was her path. And she said, I think I want to go to medical school. And I said, okay, well, are you going to have the precursors, the prereqs
Yeah.
you need for it? And she had to take a couple of extra classes, but she pretty much had it. She said, let me just take the MCAT, see how I do. And
Take
if I
the MCAT.
don't,
Like it's playing hopscotch on a Sunday.
yeah.
It's more than just take the MCAT and see how I do. I come from a gifted family, and well, I'm sure she aced it, and well, she's in med school now.
She's in med school, yeah.
Well, there
So
you
she
go.
skipped the RD. And,
Wow.
her plan was if she didn't get into medical school, which half of kids don't, she
Right.
would go ahead and finish her RD, apply for that program, get it, and then go to medical school, and then reapply. But She got it.
Tell me what is culinary medicine? We have a culinary school here in Little Rock, Arkansas. I'd love to explore
So
that.
it was the original brainchild of a doctor, Dr. Harlan at Tulane, who's an internal medicine doctor, who
Yeah.
was so interested in nutrition as a science, and in a lot of college programs, and my daughter was really picky when she looked, the nutrition degree either is more of a Betty Crocker, like
Right.
big food processing, you go
Yeah.
work for Kraft or you end up in a
Mhm.
large kitchen, versus biomedical science of nutrition. And
Oh,
LSU, where she ended up going, gave her a fantastic scholarship and it was very biomedically based. She didn't want to spend a lot of time in kitchens. She did some, it's part of the process. But when Dr. Harlan made this program, he knew that physicians, PAs, nurse practitioners were so desperate for nutrition learning. He developed this program, and it took me about a year and a half to complete it. And it's, online coursework, learning all about the science of nutrition and biomedical science and how, allergies and I mean, it
oh,
was just
yeah.
incredible. And then I had to go to New Orleans for labs and then San Antonio for labs where we worked in kitchens side by side with
Wow.
dietitians and chefs to learn how to teach our patients how to prepare food, and
Mhm.
really learn what's going on in the kitchen in people's homes and how to help guide them. It was invaluable.
Is boudin sausage included in any of the culinary? I mean, New Orleans
No.
culinary medicine's different from what we get in Little Rock.
Yeah. Boudin is something you should enjoy in moderation.
Right,
Should
right, right,
not be
right.
a staple of your diet.
Okay, so what were the first things where the blinders were lifted and you started realizing, you know what? It's not calories, as Dr. Fung says, Dr. Bickman. I mean, we don't know how really the body processes a calorie. So let's take that off the table. What was your first thing that you attacked that you thought, I think this may work and help you lose the weight?
So I was
More
focused on
protein?
the weight loss, and I
Okay,
quickly realized that I needed to lower inflammation, that why we were
right.
gaining weight despite no changes in diet or exercise had more to do with chronic inflammation. And chronic inflammation's happening in the background because of menopause and aging. So,
Hmm.
and those two are interrelated. But what could I do to lower those levels? And maybe the weight would follow. It looked like in the studies that would happen. So I looked at what in my diet am I eating that is really anti-inflammatory? The nuts, the seeds, the legumes, the greens, all of the whole grains, the healthy stuff. And then what am I eating that's really pro-inflammatory? The processed food, the carbohydrates that are processed, and really focusing on those nutrients, really not avoiding, but limiting, being mindful of the ones that are anti-inflammatory and loading up on the or are pro-inflammatory, loading up on the anti-inflammatory really started turning the needle for me. And just getting away from that caloric mindset. I was eating all this low cal, low fat stuff out of bags and boxes that was horrifically pro inflammatory, but it was low
Right.
cal. So it had to work. Right.
I
And when I
know.
learned to stop
Mm,
focusing on the scale and more about health, and all the studies that are showing that weight and BMI are not great indicators of chronic health. When I developed my menopause clinic, I bought a in-body scanner so I could measure muscle mass, visceral fat, subcutaneous fat, and really have honest conversations with people. I can't tell you the joy in patients when I tell them how much muscle they have. And they've been told
that's
they're
awesome.
obese for years. When I'm like, no, you just have a lot of muscle. You don't have a lot, your fat's fine.
That's awesome. So, how nervous are you about the GLP-1 agonists then that are reducing our ability to retain the muscle?
So I'm very nervous. I think that they're important medications. I'm really excited about the improvements coming down the line for the side
Well,
effects. I think
cardiovascular health, things
for
like that.
some patients, it's life saving.
I
We have to
understand.
look at
I
risk
understand.
benefit ratio for everyone. What makes me nervous are people are not using them properly. They're being given them, hey, you need to lose 10 pounds real fast. Here, do this. When you are not followed properly and given good advice and a reasonable plan to hang on to that muscle while you lose the fat.
Oh, so you can hang on to the muscle.
Yeah, you absolutely can. Healthy weight
Oh,
loss includes about 10 to 20% muscle mass loss. We expect that. So I
okay.
always body scan a patient before she goes on it, or we just see where her baseline is. I'm like, okay, listen, you've got plenty. Many obese patients have great muscle because they're putting on that weighted blanket every day to go do
Oh,
their life
right.
activities, and their muscles are
Right.
responding in turn. So I'm like, look, You're at 130, 120% muscle mass for your age. That's going to come off as this weighted blanket gets lighter. That's okay. But we want to keep you in a healthy muscle range. Where I get really nervous and where they have sarcopenic obesity or skinny fat, where they have tons of fat, lots of visceral fat, and very little muscle. That is not a patient who's a great start for Ozempic right
Okay.
away. We really need to help them gain some muscle before we start, doing whatever Ozempic does on multiple levels. That ends up for a lot of patients with muscle mass loss. Now, I have seen patients who've held on to every bit of muscle, but it is work. They're eating the protein, they're doing the resistance training. But I'm seeing a lot of fly by night patients who are being given Ozempic and Mounjaro and all these meds, the GLP-1s, for the wrong reason, for cosmetic, what I call cosmetic
right.
weight loss.
Right. Kardashian weight loss.
You said it.
Well, I mean, it's been said. I mean, and when Chelsea Handler, somebody who I don't prescribe to anything she says, but I've seen her on some reels that have said, she goes, my agent sent it to me in the mail. She goes, I was just told, take this, because it was back when Hollywood, remember, they had to lose the 10 or 20 pounds to stay with, whoever they were, MGM or whatever, Lucille Ball was with. So it's the same philosophy. It's just a different group of people under a different name, but it's, you keep this image to help us keep pushing you, and let's all get along. And I appreciate her candor to say, I wouldn't, or maybe she took it a couple of weeks or something because they so blindly follow their leaders. And that's just the philosophy of that, again, which is a fat phobic society and all that. Okay, so let's talk about the woman who's listening, who's saying, am I skinny fat? And she doesn't have an in-body scale. How can she figure that out?
Sure. One way, it's not perfect, but the next best thing is the waist hip ratio. And so you can do this at home where you take a tape measure and you measure the smallest part of your waist. So wherever that hourglass is for you, if you don't have an hourglass, many of us don't, or you go out, just pick your belly button. You're just going to pick a point that you can get to every time. That's always going to be the same. And then you're going to measure around your waist and then around your hips. And you're going to divide the waist by the hips. So waist on top, hip on bottom. Okay. If your waist hip ratio is less than about 0.7, 0.8 maybe for a woman, you likely do not have a tremendous amount of visceral fat. Okay. The fat that you have is mostly subcutaneous and it's probably not, of metabolic concern. If you are above 1, then the chances are much greater that you have elevated amounts of visceral fat that are affecting your risk of chronic disease. Now, I get all these comments. What if I have a diastasis? I'm like, you want to do it first thing in the morning when your bladder's empty, when you're not bloated, be sensible about how you do it. But outside of you going to get a DEXA scan or an in-body scan, which are expensive, this is an easy way. We have our students in the program track their progress, not with the scale, but with their waist hip ratio.
So I'd heard once, and this may be more for men, because men will get the pot belly, and I guess women do too, but not like a man will get like a hard, he looks like he's in his second or third trimester, and things are getting close.
That is visceral fat.
Okay, so I heard once that if you can pinch an inch, that's really almost a good sign. It's when you have, and I might not be using the right term, the hard thump that you can't get to it, that you're in trouble. Now I might have oversimplified that.
Subcutaneous fat, which is the fat under our skin, is the pinchable fat. You can squeeze it. Yeah. Right. And it's, I'm squeezing mine right now.
Yeah.
28% body fat is normal in a woman, is still in a very healthy range.
Okay, good.
And so I just say, you've got great curves, rock them when I see that in a patient.
Right.
Now, when I can see the visceral fat I'm like, when the abdomen protrudes like that, and most of the time they'll be like, I've always kind of had a little jiggle around my hips, but now like this top part I'm pressing here is starting to protrude. And this is new. My pants are tighter. This is all new. And I've never had this before.
So are you seeing then, because, these young girls that have these abdomens and then the facial hair, we start wondering about PCOS. But then I see postmenopausal women. Now I know ovarian cancer is often one of the symptoms is the big belly, but let's say that person doesn't have ovarian cancer, but she's postmenopausal and she still has the abdomen. What are you looking at there? What are you worried about?
I'm looking for visceral fat there, and multiple things are driving that. Our relative levels of androgens do rise because their binding globulin decreases. Our inflammation markers start rising. Our cholesterol goes up on its own. Your insulin resistance, your HOMA-IR score, it's all related, and you end up in this almost inflammatory traffic circle that you have a hard
Yeah.
time getting out of, where
Yeah.
the increasing visceral fat leads to more inflammation, which then drives more visceral fat, which makes your insulin resistance worse, and you just spin and spin and spin.
So what comes first in that? Is it the drop in, because we call it estrogen dominance, but it's really more of a ratio between progesterone and estrogen, right? So
So
our
we're talking about
estrogen.
menopause. Okay, first of all, estrogen dominance. I'm a board certified OB-GYN. That is a marketing term, not a medical term.
Oh, tell me more.
So estrogen dominance was created probably by someone well-meaning who was trying to describe a condition where you don't ovulate regularly. For example, PCOS or
Oh,
perimenopause. Okay.
right.
So when in a normal ovulatory cycle in a healthy woman, we have an estrogen surge mid-cycle and then a
Mhm.
progesterone surge after
Mhm.
ovulation.
Mhm.
So, and that's like an EKG every month. Boom, boom,
Okay.
boom. Then but say you have PCOS, like I did. That,
You did have
mhm,
PCOS?
yeah, I was PCOS. I was a thin
I
PCOS,
was gonna say.
anovulatory, would never have a period, had trouble getting pregnant, had to do, fertility drugs, the whole 9 yards.
Well, we need to come back to that, but go ahead on
So
the
I know a
science of
lot
this.
about this. And
Wow.
so I think someone well-meaning were like, well, you're making more estrogen relative to your progesterone because you're not ovulating, right? And estrogen levels rarely go above 3 or 400. Um, and then you're not offsetting it with progesterone each month because you're not ovulating. So these anovulatory conditions, there's multiple root causes of that. So like estrogen dominance is not a root cause term. Not like I'm trying to understand, but it's kind of been taken over by the alternative medicine practitioners and people who are really not using evidence to sell their supplements to cure these conditions. So when I'll never say you have estrogen dominance. I will say you're not ovulating regularly because you're perimenopausal. You're in the stages of ovarian
Okay.
failure because you have insulin resistance, which is leading to your PCOS. That is the cause of
Right.
insulin resistance is the cause of
Mhm.
PCOS.
Mhm.
And so when we talk about treatment and management, we go back to the root cause. Perimenopause, we give you back hormones. PCOS, we got a lot of options. We either treat the symptoms, treating the root cause of PCOS is nutrition. So,
Right. And people don't like that either. I was on a Facebook group once, and I think I got kicked out because she was saying she needed help to find a provider because she had PCOS and she needed no, didn't need a nutritionist at that point. She wanted to do something else, and I said, "Would you consider intermittent fasting because it's an insulin resistance issue?" And she said, "You have violated the terms of this group." She goes, "We all know there's not a cure for um the condition PCOS or whatever she was saying, and I got booted out of there. But Dr. Bickman, I know I've heard him say, and other people, and Dr. Hyman and other people have said it's too much insulin. And so we can
mhm.
say it's reversible, right?
Yeah, I mean, it's like type 2 diabetes. You will always be predisposed to it. We just take away the triggers,
Right.
and nutrition will go a lot. Women will start ovulating if they lose 10% of their body weight simply because if they're obese and PCOS,
Oh.
simply because they're lowering their insulin resistance from the weight loss. So,
Then tell me, riddle me this. How's a skinny person then? How does a skinny person have insulin resistance? And how are you measuring it?
this is my metformin. I'm 55 years
Really?
old. I have insulin resistance. If I don't take that, I will be pre-diabetic. Um, so how does a skinny person? So for me, I could not eat less. I was very thin in medical school, college, when I was trying to get pregnant. It was not because of an obesity issue that was overriding my body's capability. I was gestational diabetic, with
Oh.
a broken receptor
Mhm.
in my
Mhm.
body that binds
Mhm.
insulin. So I need a
Mhm.
lot more to get the job done. I have to
Mhm.
accept that. So I did the diet as much as I could. I did metformin to get pregnant. I stayed on metformin the first like 12 weeks of pregnancy, first 3 months to decrease my risk of miscarriage. And this was the best. Now, my kids are 23 and 20. So this was the best knowledge at the time.
Yeah.
I just suppressed it. I did my best with diet and I stayed on oral contraceptives until, late perimenopause to
Wow.
suppress. And I did well on birth control pills. I did great. My acne was done. I could function. I was much less aggressive because of the high androgens. I was happy and I stayed on it. And that's how I treated most of my patients until, you know, and I really worked on the diet part, especially if excess fat mass was a problem. So, but again, I didn't have the background of, I was still saying work out more, eat less,
Right.
back in
I
most of
understand.
my practice.
Understand.
So,
Yeah. Right. The blinders were still on.
oh yeah.
Now explain to me then how the ovaries are involved and testosterone and the androgen, high androgen levels are involved and make women anovulatory during this monthly cycle.
So the androgens rising is secondary to the insulin levels. So, the high insulin levels, and the IGF-1 insulin growth like growth factor 1, there are receptors on the ovary. So when we suppress ovulation, we have a higher incidence of the precursor to estradiol is testosterone. And so we aromatize testosterone in the
Right.
ovary and in our fat cells and in some of the end tissues. From testosterone gets aromatized to estradiol. That's how we
Okay.
make it. And the majority is made in the ovary. Okay. So
Okay.
when we're not allowed to ovulate, we have a buildup of estrogen that's not being counted. You're not getting that drop in the second
Okay.
half of the cycle. So we're just converting the excess of
Oh.
that to excess testosterone. Now, in PCOS, we expect testosterone levels to be 90, 100, maybe 120. Above 100 without being on exogenous testosterone, we need to look for like an androgen tumor.
Sure.
That's why I get so nervous when some of these, especially the pellet companies, are replacing testosterone in women, which I think is wonderful. And it's a practice I use, but I keep them physiologic. They're replacing them to the level of a PCOS patient or a teenage boy. And sure, their libido goes up, but there's a price to pay for that.
And is that someone who's perimenopausal, even someone who is menopausal, you worry about it?
So, in both, I mean, I think
Okay.
I'm not willing to take a patient above 70,
Okay.
in her serum testosterone levels with replacement, because that is as high as it ever would have been at 25 in a healthy woman
Okay.
without PCOS.
And do you look at free testosterone too?
Hmm.
And what do you want that to be?
So, well, I look at SHBG and
Okay.
then, I look at the reference. It depends on the lab I send it to for
All
the
right.
reference range, but I try to keep it in the normal female physiologic range.
Okay. So are you now, so do you take metformin now for life?
I would expect to, yeah.
Even though you're not, your ovaries aren't involved because they went night night.
No, but I was born with insulin resistance. That's not going away.
Wow, that's blowing my mind. I really thought insulin resistance
If
was a
you have
part.
PCOS, you are 50% likely to develop type 2 diabetes. 50%.
Right, right. But because you're thin, it blows my mind that you still have
Yeah.
to chase it.
25% of patients are thin. So I thought I was okay. I'll be honest. I thought I was okay. I was doing okay. My A1C was like 5.1. That's amazing. I was like,
Yeah.
yay. All of a sudden, even with HRT, and maybe because I started replacing testosterone, for muscle, okay,
Yes.
my A1C started going up, 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 up. Nothing
Oh.
had changed in my diet. Well, maybe a little bit, like we all kind of fall off a little bit.
Sure.
And I was like, okay. And then it got to like 5.6. One more tenth of a point, I am pre diabetic.
Yeah.
So I'm like, all right, let me do my HOMA IR score, which is a ratio of your fasting insulin to fasting glucose level. It should be below 2. Mine was 3.6. I'm like, I cannot deny this anymore.
What was your
Okay.
fasting insulin?
14. I have to look it up.
It was that high?
Oh, yeah.
Oh my gosh.
Yeah. So I was like, I have a decision to make. So it's on right here under my shirt.
Right.
I got a glucose monitor. I paid out of pocket. I don't qualify for it. And I'm like,
Right.
I'm going to be proactive with my health. and I started tracking my glucose, and it blew my mind. My overnights were in the 120s. That is full diabetic range.
Oh
And
my
I'm like,
gosh.
I took to the bed for 2 days. I cried. And
I
because
bet.
I was like,
Right.
and I
How
was like,
could this
oh no,
be? Yeah.
you are, why do we wait until people have the disease before we
I don't
intervene?
I don't understand that. I think this is what I think, because there's no drug that Big Pharma has created to tell us, to have us test the fasting insulin, to tell, because that's the smoking gun, is fasting insulin. If it comes up, there's a problem.
So, and this is, I was born with a broken receptor. I can't do anything about
Okay.
that. I've lost 3 brothers. Okay. I don't have a surviving sibling past the age of 57. No, I'm lying. One of my brothers is 60. My 2 brothers that died were at 56 and 57, and the other one at 19. Okay.
Oh, that
All
makes me
one,
cry.
2 from
I'm so
cancer. One.
sorry.
So I am very, very serious about this. So if I get the chance to live, like I don't want diabetes to take me out or
Right.
shorten or make me not have a quality of life that I
Right.
don't want. So these are the things I talk to my patients about. These are the interventions that are available. No insurance isn't covering it, but I have a budget for my health. And it's,
Yeah,
insurance is made to take care of you when you're sick,
that's right.
not to
That's
keep you well.
That's exactly right. So I was going to ask you if you wore the CGM, and you
Uh-huh.
do,
Yeah.
and still till this day.
So I started about 4 months ago.
Okay, you know what you're eating and doing every day. Do you have any hiccups or anything now?
Alcohol.
Well,
Can't do it. Not me.
I can't either.
I can't
And
sleep. My blood sugars go
I can't either.
crazy.
It's not worth it.
It's over it. I'm over it.
It's not worth it. I'm all about I mean, I have the biggest bottle of Mountain Valley sparkling water you can find. But now I went to Trader Joe's today, and they have Italian sodas. That's going to be my bubble. We're having guests tonight for dinner, and I'll just have that, and I'm fine. I mean,
Mhm.
I can't tolerate it. And I almost had a funeral for it. RIP. I miss Prosecco. Prosecco, I still love you. It's just, it's
You had to
not
break
you.
up.
It is me.
Yeah, like one day I was like, I think I have to break up with alcohol.
I
It's
know.
just not,
I know.
there's no upside for me,
No,
you
me
know?
neither. And I mean, when did it bother me? It didn't in my 30s and 40s. It didn't
Mm-mm.
bother me, but sleep is so valuable
I'm
to
not
me.
willing to sacrifice my sleep anymore.
I'm not either. And so think about all those years then. You were training in medical school, you're doing your residency. Think what it did. It also probably exacerbated the situation, because we know Dr. Bickman says one night of poor sleep makes you insulin resistant. Well,
Mhm.
you're already living in insulin resistance land. And then your schedule, eating out of the vending machine. They brought the
Mhm.
doctor. I love it how they bring the
Oh,
doctors a tray of donuts.
I had my pocket always had graham crackers in the little, from the patient. I
Yeah,
lived on graham crackers and
I
peanut
know.
butter from the patient, like supplies.
I believe it. I believe it. Yeah, I was at media, morning radio, so they always brought us food in the morning.
Donuts. Yeah.
Donut. So once I became an intermittent faster, if they brought us a treat, I would take it and I would eat it at 1 p.m. that day. And you know what? My life is a lot better. But I was getting too little sleep. So even if they needed me on CBS this morning, I would have to tell Gail and them I can't do it because my sleep is too valuable. And you wonder how their sleep is. You wonder how people that, I mean,
I mean, I worked in medicine where the night shifts and I did 24-hour call for 3 years straight,
that
like
should be against the law.
I
mean, we
agree.
don't let pilots do it. Why would
I
why would
agree.
we let anyone else?
I totally agree.
Okay, let's talk about some other things I've heard you say. Now, this one is a shocker, but you do or don't love dim.
I don't love it.
Why?
Why do you love it?
Because I was told I had to take it because it's broccoli in a bottle, and I eat pretty much a carnivore diet, and that's my one thing of broccoli.
Okay. I eat the Brussels sprouts.
Well, they make me toot.
And the diindolylmethane is what it is. It's making you toot. It's making them smelly.
It is too.
Yeah. It's methane.
So I should replace it then and go back to Brussels sprouts and just
I would
toot
eat the
on my
Brussels
own.
sprouts and the broccoli. Yeah.
Okay.
Because they also have
Because
fiber and
am
other
I
vitamins, minerals, and nutrients. And what I
Yeah.
worry about where,
I understand.
I don't need to eat my broccoli, my Brussels sprouts because I'm doing my DEM.
Yeah.
Okay, the studies on DIM were done on people eating a lot of Brussels sprouts and broccoli, not DIM.
Oh, okay. That's good. Okay. So, with that, let's talk about the woman who has chosen a life of no hormone replacement,
Mhm,
besides the fact that she's wrinkly, she aches, she has all these other risks. But
mhm.
why don't, I don't get a commission if someone takes hormone replacement or not. I
Right,
just
and
know better
I
that
don't
it's going to help them. So you
so,
tell
no,
me, kind of tell
there are
me,
people who have absolute contraindications who absolutely don't want it, like, I respect that, that is you, just as long as that decision is based on facts and not fear, but let's say, okay, you're not
right.
getting it, alright. I in the new book, the new menopause, I go through so we have to go symptom by symptom. There is nothing that is going to do the job of estrogen, progesterone, and testosterone in your body. Nothing. Okay.
I know.
So now we have to look symptom by symptom. Hot flashes, night sweats, vertigo, burning tongue, whatever. I have a whole list of what I could find in the literature of what supplements might help, what doctor to go to, how to talk to them about this condition being related to menopause, you know, what exercise, what stress reduction, what we know in the menopause toolkit outside of hormone therapy and other pharmacology might be helpful in those diseases. But the root cause of a lot of this exacerbation, not to say that aging can't bring on some of these diseases, of course it can, but is estrogen deprivation, and fixing it is giving you back estrogen in some form that's going to make sense to your body. So if that's off the table for you, you have to work harder than everybody else. It's a
But
fact.
what can they do? I mean, lick a Dutch elm, hop on one foot. I mean, what? Where?
Well,
There's
hopping
only
on
the
one foot will help
magic.
with osteoporosis, shockingly.
Well, that's true. That's
You
true.
know,
Yeah.
you really have to go symptom by symptom. It's much harder
Okay.
for you. It is much harder to stay
I
healthy.
I I saw a woman yesterday who works in media, and I hadn't seen her in a while. And I walked over to her, and she was like, "I can't turn my neck. I have a crick in my neck." And she's probably about 65, and I'm 61. And she said, when you're old, you ache and all. And I went, "No, I really don't." And I didn't mean to sound smug, but I mean, I really didn't answer. I know it was rhetorical, but the answer is not if you have hormone replacement.
I
I don't
mean,
have any aches and pains unless I have gluten. And then, but that's the penalty I pay with, I
mhm.
get hip bursitis. So my doctor, my son's a physician assistant in ortho. So he's like, yeah, we see women with that in their 50s and 60s. Right. And so I said, tell them to stay off gluten and see if they still get it. So if I if I know the offending substance, then I've made the choice to suffer that night. But there are just a lot of things I don't have that my peers have because I'm singing with hormone replacement.
So, estrogen, as it turns out, is better at keeping a cell healthy and non inflamed than stopping that process once it gets started. And the longer your body is without estrogen, the more likely you are to have these inflammatory conditions.
So can they at 60 or 65 start hormone replacement therapy if
Yes.
their menses ended in
Yes.
their 40s or 50s? Okay.
So, the longer your body goes, so the studies were done for 10 years up to age 60, and then they
Right.
stopped the
That's what I
study,
thought.
right?
Hmm.
Well, and so here's what we know. Estrogen, again, better at prevention than cure. It's protective against cardiovascular disease. So the big
Right.
two things are cardiovascular disease and neurodementia. And within 5 years of your menopause for dementia and 10 years for cardiovascular disease. What I tell patients is we may have lost that benefit, but it's probably for cardiovascular disease prevention. But you will still have better bones, a better general urinary system, better brain, better thought process. If you have existing coronary artery disease like calcified plaques, certain types of estrogen may make this worse. So I have them get
Oh,
calcium
the
cardiac
CAC.
scores if they're
Yeah.
in their 60s and they have, risk factors, if their cholesterol's high or whatever. They come in with their score to show me, okay, I'm
Yeah.
clean. These look
Mm-hmm.
good. I mean, all these look
Mm-hmm.
good. I'm like, okay, I'm not worried about making this worse. Certainly if they're on the path to Alzheimer's, they're not a candidate. It looks like in certain patients who have advanced disease, estrogen may be harmful. Much better at prevention than cure.
Okay. All right. Case by case,
Mhm.
like we
Case
would
by
say for
case. I
anything.
have lots of patients on their 60s, but I have some who we've decided as a team that this is not in your best interest, given what's going to keep you up at night, your fear of someone who
Yes.
has, for example, I had a patient who's 59, but she'd been menopausal since like mid 40s. So she'd long time. Never,
Yeah.
was scared to death of hormone therapy. No one ever offered it to her. So here she is,
Oh.
12 years without it. And her mother had horrible dementia.
Oh.
And, so in her particular situation, probably, as far as we understand the data right now, probably not in her best interest. So we're hitting all the other things. So there's some really exciting research coming out on the FSH level. So I'm
Okay.
starting to track that,
Oh.
especially if they are still symptomatic and I'm giving them X, Y, and Z, I'm checking a serum level to make sure they're absorbing, because we may need a different vehicle,
Okay.
right?
Right.
Okay. But now it's like their hot flashes are good, but their cholesterol is going back up. Great
Right.
study looking at FSH levels in cholesterol. So FSH, remember, is made in the pituitary gland from GnRH in the hypothalamus, and it basically is trying to get the ovary to make more estrogen. The ovaries have died, right? And
Right.
so the brain is not registering that you have enough estrogen. And some scientists think it's the FSH that is driving the elevations of cholesterol, not the estrogen deprivation. So
Okay.
for
I
my
thought that
patients whose
was
cholesterols are not rebounding with HT, I'm sending an FSH and I'm a little bit shocked. So I'm trying, and then I'm upping their dose till we can get their FSHs down.
didn't even think FSH was a player anymore because of
I didn't either, but
RIP to the
this is new.
ovaries.
And then all of a sudden, so that's the hepatologist talking about it. And then, no
Oh.
one in OB-GYN
Okay.
is talking about this in the literature. They're still talking about babies, which is fine.
Yeah,
But
that's true. Yeah.
um, which is important, but like menopause just gets left on but all of a sudden it's really cool because the explosive literature in menopause is coming out from the cardiologist, from the hepatologist, from the orthopedist, not from OB-GYN.
Okay, then when are they going to start teaching it in medical school?
I am doing my damnedest. I've got 4
I know you are.
appointments to fly around and go to go on my own dime to go teach residents what I
Is
know.
that right?
Mm-hmm.
Why wouldn't he be a part of the curriculum? Because it's inevitable. Women are going to, their ovaries are going to fail.
You tell me why.
Okay.
There's societal reasons. There's this whole
Yeah.
medical history of women's health just being secondary to
Yeah.
men's health. We
Yeah.
haven't, the research funding is heavily for obstetrics and OB-GYN. All
Yeah.
these machines have been built around generating research around OB, which is great, even though we're really not improving the maternal health in this country, though we're spending
shame.
billions of dollars on it.
Yeah.
And I feel like what I'm doing is not rocket science. I'm not trying to get you 1% healthier, right? As a lot of this, I love Peter Attia. I love him, but he's really trying to get healthy people 5% healthier, right? And I'm just trying
He's
to get
obnoxious.
women up
Yeah.
to anything. They're getting nothing. They're getting left behind simply because we have ovaries. And I'm like, medicine, we have got to catch up. So, the talk is there. We just had a bill signed. Like, things are happening, but we are a generation away from large scale, acceptance of menopause as medicine.
Well, now thankfully to social media, it's being talked about. Lisa Rinna was on I just saw on social media.
Everybody's waving their menopause flag, and I am here for it.
Right.
All these companies are popping up. I'm like, bring them.
Good. Good. So when you run for office, will it be as the representative from Galveston, or will you go back over to Lafayette?
I don't think I could run for office in Texas.
Why?
It's Texas.
You know why? Because you're a truth teller.
So people, it's really cool because menopause is not drawing party lines. It's everybody.
That's right.
I get full support from both sides of the aisle and then in the intermediates. It's everyone. So maybe I love Texas. I live here. I raise my babies here. They're Texans, I love it. Little tough when you're a gynecologist here.
I'm sure.
So, but it's my choice to live here. I could live anywhere right now. And
well, you do amazing work. You are such a proponent for women. We thank you. My dead uterus and ovaries, my dead ovaries, thank you. My sagging boobs, thank you. But my skin looks good because I'm on hormone replacement therapy.
It does.
And it's things like that people ask me. They're like, why does your skin look good? Now I've had lasers and stuff, but part of it is rejuvenating my hormones of my youth that keeps my hair in good shape and my skin in good shape. And
So 30% of our collagen declines in the first 5 years of menopause. We lose it.
oh, well, there you go.
That, if nothing else gets people to consider hormone therapy, it's going to be that.
Yeah. That and painful sex. That's another thing that a lot of people will say. Painful sex is what made them think, I've got to do something about this. I tell you what, my big symptom is when I feel like my estradiol starts getting wonky is peeing in the middle of the night again.
Mm-hmm.
And not much pee comes out. Or sometimes
it's just
a lot
irritation.
of pee comes out. But yes, it is so irritating.
So are you doing vaginal estrogen?
No, I'm doing the one you don't like, the pellet.
Oh, well, just add. That's fine. I don't care. Just add, watch your testosterone levels. Don't let them overdose you.
No, I can't do testosterone pellet because it full grown beard, acne.
Okay. So you're doing estrogen in a pellet. That's fine. Just vaginal estrogen. You probably just need a little extra boost down there. A vaginal estrogen cream. Just ask your doctor, and that will take the irritation right away without having to go so high systemically.
Yeah, I don't want to do that. Here's my testosterone. I even keep it besides my podcast.
Oh, so you do that's what I prescribe for my patients.
For that and progesterone. I've been doing progesterone because of those. I was getting up at 3:45 to be on the radio, but on my own, I would wake up at 3 a.m. Wide awake, back when I was in my 40s. And my husband would go, well, what's 45 minutes? I'd go, everything. Everything. And so that's when I first got with a functional medicine or a nurse practitioner who said, let's start doing progesterone. And it's nature's sleep aid. I mean,
I love
progesterone.
I love it. Yeah. And I'm, when I put patients on it, I do it every day. I don't do cyclical because of the sleep benefits. I'm like, why should you only sleep 2 weeks out of the month?
Okay. I was going to ask you, well, I heard Deb Matthews say, take the 5 days off to mimic your cycle. You don't even do that?
You don't need a period. Why would you have a period if you didn't have to have one? Like,
come to me, mama. Here, then right there. It's going to be every night. I was taking the 5 nights off. Can you get too much progesterone, do you think?
I don't know of any progesterone toxicity.
So it's fine. It is wonderful in the sleep aid department.
In the prometrium, because of some people might get, it's sedating, which is why it helps with sleep and it helps relax. So some people, not everyone tolerates progesterone. So let me say that it's not toxicity. It's just intolerance.
Okay.
And so you will see some people are really groggy and too sedate. Like the next day they can't wake up. So that would be a sign to back off.
Well, chef's kiss to you now that you're culinary medicine, MD, PhD, DDS.
No PhD, just MD.
Well, you have every other, I'm sure.
I do.
Yeah, school training and little star by your name. Thanks for what you do, and you're a star. And I really appreciate you being on my podcast. Thanks for listening to the Lisa Fisher Said podcast. Be sure to hit subscribe and download all the episodes and leave a review, won't you? The Lisa Fisher Said podcast is produced by ClantonCreative.com.